The first papers we're discussing are Nakamura, ctDNA-based molecular residual disease and survival in resectable colorectal cancer, Nature Medicine, 2024. Katoka, survival benefit of adjuvant chemotherapy based on molecular residual disease detection in resected colorectal liver metastases. Subgroup analysis from Circulate Japan Galaxy, Annals of Oncology, 2024.
This was a wonderful cohort that came out of Japan that was utilizing a tumor-informed ctDNA, meaning basing the ctDNA test on the sequencing of the tumor itself. And this showed that the results were highly prognostic. So there's two different settings, what they called MRD window, post-op, right? This is immediately after surgery, and then surveillance, which is after finishing adjuvant therapy. And we can see huge differences. I mean, these are really clinically significant differences in prognosis between those that had post-op positive versus negative. And you can see the really flat line on the overall survival, and you can see a nice separation of radiologic recurrence. The same we see with the surveillance. Again, here's the post-adjuvant, and hazard ratio of 33. I mean, this is a tremendous prognostic difference in these patients during the surveillance window, and overall survival likewise, really compelling difference there in those settings with very few recurrences there. So this really has become one of the largest and one of the first cohorts to really, with such large numbers, to robustly demonstrate that prognostic ability in colorectal cancer. And I think has become a real seminal paper in the field, and certainly worth reading if this is of interest.
What about this subgroup analysis from Circulate Japan Galaxy?
Yeah, so the subsequent question then is, okay, can we use this to help define who may benefit from adjuvant therapy? So first thing to acknowledge is this is an observational, so they did not randomize patients to receive adjuvant or not, but we're looking in general practice about the differences there. And this was in patients with the liver metastases as well. But what you can see is, again, MRD window, that postoperatively, obviously this is a higher risk population, resected liver mets, but nice separation both in recurrence as well as overall survival. The subsequent question was, is there association with kind of efficacy of adjuvant chemotherapy after liver met resection? So nice separation here in OS and DFS. But the real interesting finding was that there wasn't really clear that giving more chemotherapy after liver met resection was substantially improving outcomes, that this is really prognostic, and that it instead is not it may help guide us to understand who needs adjuvant therapy. Again, kind of nice additional set of data in the field.
This is Signatera?
This was using the Signatera whole exome assay.
The next papers are Shah et al., Circulating Tumor DNA for Detection of Molecular Residual Disease, MRD, in patients with stage 2-3 CRC. Final analysis of the bespoke CRC subcohort. GI Cancer Symposium 2025, Abstract 15. Osterland et al., Circulating Tumor DNA, ctDNA clearance and correlation with outcome in the Intercept Colorectal Cancer Study, ESMO 2025, Abstract 732MO. Let's talk about these next two papers, final analysis from the bespoke CRC trial, and then some more data from your Intercept colorectal cancer study.
Yeah, no. Absolutely. So the bespoke study was a prospective study where we enrolled patients with the idea that this was information that we would collect on patients, really understand more about the patients than we could from a retrospective study. There's no intervention pre-specified, so it's purely a prospective observational study. This study looked at multiple different time points, a little more control over the time points, more data that helped us interpret this compared to other cohorts. This demonstrated because importantly, this information was returned to the providers and the patients. So unlike the observational studies where the patients and providers didn't know about the results, the question was, did this make a difference? And the finding was that about 1 in 6 assays that were run influenced how the patient is being managed by the provider. The correlation showed a really nice separation, again, in stage 2, what otherwise would be a low-risk population where you can see a really high recurrence rate, as well as in stage 3. Now, one of the things we could ask is, did the ctDNA disappear during adjuvant therapy? And the answer there was that yes, if you got clearance during adjuvant therapy, that you had much better outcomes. And this was both at month 3 as well as at the end of adjuvant in month 6. When you looked at again, not randomized, but when you look at who got adjuvant and who is observed as part of clinical practice, what you can see is that the positive patients, those that got adjuvant therapy, much better outcomes than those that didn't, who had that. But the converse, those that did not have any ctDNA detectable, it's really overlapping curves. So the conclusions that we had out of this was that that adjuvant therapy benefit was exclusively seen in the MRD positive, not randomized, but observation, and that there was a lot of patients that this really was impacting the management in some way.
When you saw clearance with adjuvant therapy, was that clearance associated with benefit?
Yes. So those that cleared had better outcomes, lower risk of recurrence than those that did not.
Interesting. Kind of almost, kind of like a tumor marker in a way. I mean, even though it's not quantitative, it kind of seems like it's functioning that way.
It does. And when we think about what it is, when it has a really high positive predictive value, one way to think about it is this is defining molecular residual disease. It's not a risk factor. It's not a prognostic marker, but it is defining disease just like a CT scan may define metastatic disease. And so when you think about it that way, you can say, yes, it makes sense that we can define a population that may derive benefit.
Yeah, it's interesting. In the plenary presentation at the ASCO meeting, when the breast study, where they were looking for ESR1 mutations, the discussant referred to the presence of ESR1 mutations as molecular progression, even though actually it's really a mechanism of resistance. But here you're really measuring output from the tumor.
Right, absolutely. And because of that really low rate of false positive, that you can really feel comfortable that what you're seeing is disease.
So here's some more data from your INTERCEPT study. Can you talk a little bit about what you looked at there?
Certainly. So this is our INTERCEPT study, which that totals about a 3,000 patient cohort. This is reporting on the first 1,300 with mature outcomes. And the question here was really asking, when we're monitoring these serially, can we better understand what the natural history of a ctDNA positive test is? And how often do we see a positive then changing to a negative without doing anything? And how often is that durable? So again, like was seen before, their adjuvant therapy was able to clear and durably clear the ctDNA after surgery. But when we looked at the next time point, which was looking at patients after completion of adjuvant therapy, and then asking the question, how often did those clear spontaneously? The answer there was very low. It was about 2% of patients that were positive and without any further intervention then became negative and stayed negative. So we do think that, maybe lifestyle, other things that patients are doing may be able to convert a rare percentage, 2% of patients who are positive to negative. But that does mean that 98% of patients will stay positive, will recur. So we've acknowledged that need there. This is just showing the DFS from in the difference between stage 1 and 3 and stage 4. And the kind of key component here is that those are really high risk patients in stage 4, but that those that clear can have better outcomes. So this is kind of the figure to maybe remember, is that of the 400 patients that we had that were positive any time after surgery and adjuvant, 2% were sustained negative on subsequent tests without any subsequent intervention. So it can happen, but it's very rare. Now, the other way we use that is to say, okay, that's the natural history of it. Now, if we can bring in a novel therapy, if we can bring in a novel intervention, and show that we can durably clear 30% of patients. We can do that with a small number of patients. That's a small phase 2, 30-patient study, right? And we may be able to really accelerate novel drug development in the MRD setting. So that's the explosion of new studies we see coming, and I think the real excitement in the field.
So I'm just kind of curious, again, to draw another analogy outside of colorectal cancer. How would you compare the clinical value of what we know about this? I mean, I don't know how much you follow prostate cancer, but PSA in prostate cancer has, to me, always been the best biomarker that I know about. Seems to be quite reliable, although there are people who do become a PSA positive who never have a clinical relapse, at least in their lifetime. Do you think that cell-free DNA, and particularly these bespoke assays, are kind of have similar power?
So they do. They have good sensitivity, especially when done serially, like PSA, where you can see kind of trends over time. The one advantage here of the ctDNA over PSA is the really high positive predictive value, right? So so there are very few patients that don't develop recurrence with a ctDNA positive test.
The next paper is Dasari et al. Clinical utility of including circulating tumor DNA, ctDNA monitoring in standard of care colorectal cancer surveillance. ESMO GI 2025, Abstract 20. So our next paper is actually from the ESMO GI meeting this year in 2025. Your colleague, Dr. Dasari. Can you talk about what he reported?
Yeah, so this was looking again at some of the ctDNA that is tumor-informed and asking the utility of this in standard of care during surveillance. So this would be kind of after completion there. And what was seen is the question about, if you have this information, how is that associated with the ability to do metastasis-directed therapy? And what you can see is that about 22% of patients who are ctDNA positive were able to undergo metastasis-directed therapy during surveillance. So the hope is that we're showing that is better than the CEA results, that ctDNA gives you much better clarity there. But the hope is there that this can be utilized to really intensify surveillance, pick patients up for metastasis-directed therapy before you would otherwise. And those patients with persistently negative ctDNA on contrast, what you can see is that your chances of recurrence, if you have a year's worth of ctDNA negative results, your chance of recurrence is 0.9%, right? So
Wow.
Really low, and that's the confidence that comes with that kind of serial monitoring during the surveillance setting. And this, again, very similar findings here, and those are looking at patients with recurrences and really when those are occurring. What we can see is that stage 4, not surprisingly perhaps, but those resected liver mets and lung mets are more likely to have positivity immediately after completing surgery and adjuvant, or in the first few time points. And this one's showing also in the adjuvant, in response to adjuvant therapy, that can delay things a bit. So you get about 3/4 of patients that will have molecular recurrence by 12 months, and then over 90% of patients by 18 months. So the idea is that ctDNA is most useful probably in those first 2 years. There's questions always come up, how long do I monitor my patients with ctDNA? And we don't fully know the answer there, but most of the benefit, importantly, appears to be in those first 2, maybe 3 years after surgery.
Sort of taking a broad view of the research we're talking about here today, maybe you can comment a little bit about bespoke versus non-bespoke assays, which bespoke assays are out there. You hear a lot about Signatera, maybe there's some other ones. And from your perspective, is there a preference in terms of this type of work?
The current ones that are used predominantly right now in the field are the kind of tumor-informed ones. Now, there's some downside. It takes a little bit longer to get the test result initially, not the subsequent ones, but initially, because they have to build your own panel. But it gives you that really high positive predictive value, right? So this idea to say, I feel really confident if I see a positive that it's real. We don't quite have that amount of data yet for those that are not tumor informed. So if you don't have that information of that tumor, the test can be better than nothing, but don't have that same performance. New ones are coming. Whole genome approaches where, and then ones that may not need a bespoke panel, so maybe a little faster there as well. There are at least a dozen companies and 3 or 4 assays that are already in the market that are available for testing. We don't yet know kind of head-to-head which is better, how much better the novel methodologies will be.
That's what I was going to ask you. Has there been any studies where you take the same sample and have 2 different assays done on it?
Yeah, it's a great question. There's some efforts to try to do that. Indeed, I think there are limitations in terms of how much blood you can take from a patient. Typically, you need 2 or 3 tubes of blood from a patient for one assay. And so that limits our ability, for example, to say, let's run 3 or 4 assays on the same patient's time point.
The next papers are Tai et al., Circulating Tumor DNA Analysis Guided Adjuvant Therapy in Stage 2 Colon Cancer, New England Journal of Medicine, 2022. Tai et al., Circulating Tumor DNA Analysis Guided Adjuvant Therapy in Stage 2 Colon Cancer, Overall Survival and Updated 5-Year Results from the Randomized Dynamic Trial, ASCO 2024, Abstract 108. Dasari et al., colon adjuvant chemotherapy based on evaluation of residual disease, Circulate North America, NRG GI 008, ASCO 2025, Abstract TPS 3644. So a couple more papers I wanted to ask you about. One was from last year's ASCO from the Dynamic trial, and then the other one was this year's ASCO, again, Dr. Dasari, looking at some data from Circulate North America.
And so the Dynamic study for stage 2 is the first prospective study to define a benefit for the use of ctDNA-defined management. So this was looking at stage 2, right? And so very pragmatic Australian study looking at adjuvant therapy as per standard of care, or CT-guided management, where if patients were positive, they would then go on to receive adjuvant. If they're negative, then they would receive observation. And then patients were followed. The key thing is that, of course, ctDNA recurrences are rare in stage 2. ctDNA positive is rare. So those that were ctDNA guided had about half of the amount of adjuvant therapy as those with standard management. And what you can also see is that the much lower use of oxaliplatin, but when you were positive, they were more likely to use the doublet there. And what that showed is even though we're using half the amount of chemotherapy, the outcomes were really equivalent, really overlapping curves here. And the idea of the 5-year overall survival really overlapping there. And especially when we look at colorectal deaths, really no difference is present. So this is mature data, really convincing. It was a New England Journal publication, has really made its way into the guidelines as we discussed. Now it's in NCCN that ctDNA can be used to help prognosticate and select treatment for stage 2 patients. And this is data that really says that this allows us to better tailor our therapy to our patients. Now, the Circulate North America is now asking the question about what about stage 3 patients? So this is now enrolling as well. I will say this is incorporating some of the high-risk stage 2s that you would traditionally want to give therapy. So there's 2 cohorts. There's the question about can we do better by escalating treatment if you're positive? And the second is then can we avoid chemotherapy in those patients that are ctDNA negative. And so what you see is that if you're negative, you're randomized either to standard of care, which is getting your adjuvant therapy, or serial surveillance. Now, this is important. It's not just a single time point, but you're embarking on a series of surveillance with the idea that if ever in the future, over the duration of surveillance, if you become positive, then you go on to get adjuvant therapy. So, but if you never turn positive, you never would get adjuvant therapy for a stage 3 patient. So that's the key component here. Second question about can you escalate up and add irinotecan on there? The Dynamic 3 asked a little bit of that question, and it was a smaller study, and we'll still wait the results of Circulate North America. But the idea of really trying to do more is really inherent in how can we improve outcomes for those patients that are positive.
So I'm going to guess that you're entering patients on this study?
We are, yes. It's enrolling well, both in the U.S. and in Canada. So hopefully be able to get some results here in the next 2 years, perhaps, to really help guide further how that we can manage these stage 3 patients.
I was kind of just flashing on what it's like to sit down with a patient and do an informed consent on this trial. You almost have to be a medical oncologist to really understand what you're doing here today. How do people respond to this?
Yeah, I think there's a lot of interest in how we can better personalize the therapy there. I think the key part when we're discussing with the patients is that not that we would be not giving adjuvant therapy at all, but really only bringing adjuvant therapy in if we think you need it by the ctDNA being detected. And so it's really a randomization to a strategy of immediate versus potentially delayed adjuvant. And that's been well received by patients in general.